All right. Good evening, everybody. Think we will get started and others will join as they come in. My name is Ting. I am part of the University of Washington Global Anesthesia Initiative, and we are very excited to launch the first of our three-part virtual lecture series. This is a collaboration that we've been working on for quite some time with Naivasha Sub-County Hospital, University of Nairobi, and University of Washington. This year, we will be focusing on pediatric anesthesia topics with this first lecture on Airway. We will have subsequent lectures on CPR and pediatric resuscitation, as well as on fluid and blood management. Just a reminder for everyone joining to please mute yourself so that the speakers may have all your attention. And without further ado, I would like to introduce our speakers for today. They will be speaking on the topic of pediatric airway management with Dr. Shuweika Salim, a pediatric anesthesia fellow from the University of Nairobi, and Dr. David Liston, a consultant pediatric anesthesiologist at University of Washington in Seattle, USA. So thank you, everyone, and I'll hand it to our speakers.
Hello, good morning, good evening. I hope everybody is doing great. Welcome to this great presentation. I want it to be as interactive as possible. So if you have anything to add up to question, just raise your hand and ask, even in between the slides, so that we can make it more interactive so that people get to understand more. So we're going to go through management of the pediatric airway. And the only great thing about pediatric airway management is that it's been in charge of many non-anesthesiologist providers in our settings. And a lot of the critical event analysis on these reports are journals. So we want to go through this particular topic with emphasis on how to really manage that airway to get your patient oxygenated and ventilated without any bad outcome. So with our lecture today, the disclosure, there's no relevant financial disclosure, and we're not intending to imply any in such a relationship. What's the main learning objective for today? We want at the end of the teaching for you to be able to recognize and evaluate any respiratory failure, to be able to describe a proper airway evaluation, be able to predict the difference between difficult face mask ventilation and difficult intubation, to be able to have an effective face mask ventilation technique, which is our life-saving technique right now, and how to be able to put in LMA placement and how it's placed because it's your rescue, and to also be able to do direct laryngoscope, and as things are evolving to be able to the video laryngoscope, the fiber optic, all those, and major complication in airway management, and also review American Society of Anesthesiologists difficult airway algorithm, because we need to go through that. So to be able to know what's your steps to take when you're having a difficult airway, and any recent airway literatures that will be gone through today. So what's the background? What has always been done before? The main focus on us teaching or passing the information in terms of an airway is that we were all giving the role of direct laryngoscope. So we want to decrease this role because people are more focused on doing direct laryngoscope rather than ventilating or oxygenating or passing in air into our patient. So we want to give this emphasis that effective mask ventilation is the critical initial step in your airway management. Nothing stops with your direct laryngoscope difficult, your intubation difficult, provided you can effectively face mask ventilate your patient. With evolvement, there's new airway devices that are coming up, which are now an alternative to direct laryngoscopes. But the most important thing for today's presentation or today's teaching is your team approach. Because when you're managing a pediatric airway management, you need to have this teamwork and your sentimentals of human factors and this thing that is called now a crisis resource management or a crew resource management that is used to mobilize and plan and communicate. After that, you give an action, and then when you do an action, this is part of your crisis crew management or your crisis resource management or your crew resource management, which the most problem that was found due to the studies that were done is that the human factors was the main issue and the non-technical skills were the most problem. So now the anesthetic crisis resource management is using a team-based approach to be able to identify and to be able to manage any potential crisis so that we can minimize patients' harm and get and optimize a good outcome. So all that we will come out from this presentation, all the skills, but our team approach should always be our first, and our effective communication, that is closed loop. I hope everyone understands what closed loop communication is, or I can give an example, which is closed loop communication is that you need to keep on repeating what you've done, repeat it again for the person that has given the order, done the order, and say it again that the order has been done. So this is all closed loop communication. But the emphasis on it is teamwork, communication, a good leadership, situational awareness, and a dynamic discussion making after all this. And we get our review on that assessment. Next. So what do you see in a patient? Let's dig in now. What is there in a patient with respiratory distress? We are seeing changes. Which changes are you looking for? Your respiratory rate. Your respiratory rate will start going up. The effort of the patient will start going up. Before we start decreasing, you'll have abnormal airway sounds, which can be stridor, can be a wheeze, can be a grunt. You'll have an increased heart rate. And as these are not approached or these are not dealt with early enough, you will lead to all those respiratory failure, changes in your mental status, and all this can be managed or can be identified by you just looking at the patient from the door. Because you can only identify all this by just seeing the patient. How is the patient breathing? Or that patient is breathing very fast in according to their age. Remember, we're dealing with pediatric patients. So each respiratory rate is age related. So you have to know, oh, this is a 12-year-old, what is the age? What is the rate for respiration? This is a 2-month-old, what is the rate for respiration? So, and how is this patient breathing? Is he using or she using force and effort? Is the effort too high? Is the effort low? And all this can be picked by what you see: a nasal flare, a retraction, the use of accessory muscles. These are all signs that are showing you that this patient is using too much effort, or it has an increased respiratory effort, or working too hard to breathe. So when you see such things, you need to have a sequence of what you're going to do. So you're going to call for help, you're going to give your oxygen, and you're going to put your monitors, if they are available, for you to be able to keep on monitoring the sequential of your patient. So next, what is our normal respiratory rate? So in PALS or in pediatric air, provider manual, sorry. There is a normal respiration rate that is just kept there, which we have to laminate, put in our pockets. You don't have to learn the numbers, but you just need to know roughly where you are. So those are our normal rates, respiratory rates in accordance to age. So when you see there's, let's take an example for toddler 1 to 3 years, we have 22 to 37 rate, right? So you have a rate that is less than 22, you're worried. You have a rate that is more than 37, you're worried. All these things you have to pick them and understand that, okay, this is not a normal rate. What is the issue? Is it something that can be cleared right now? Is it an oxygen? Is it a backup of something? Because even tachypnea can be a problem of cardiac. So you have to all pick on what is the issue. So in a consistent of respiratory rate, anything less than 10 or more than 60 to be roughly around there shows you that this is an abnormal and it warrants for more further assessment. Next. So in respiratory distress, what are our initial impression? So we have an increased work of breathing, we have an increased respiratory rate, and we have an increased respiratory effort. This is what the patient does to fight whatever is giving a distress to the patient. The brain is telling the patient, you need to breathe fast, something is wrong. You need to increase your work of breath, something is wrong. But as this is not assisted or this is not helped, the patient will now progress into an irregular breathing. He get tired, he will decrease now the effort, and it will eventually progress to respiratory failure, and it will ultimately lead to a cardiac arrest. So keep treatment as simple as possible and as fast as possible so that you don't lead to an outcome that is not needed or a bad outcome like a cardiac arrest that could have been avoided. So there are more of a logarithm that can be followed, simple logarithm, user-friendly, that don't need any difficulties in managing your already difficult airway. Always remember, focus on maintaining that situational awareness. What is happening around you? What do you have? Whom do you have that can assist? This teamwork approach based on what airway you're dealing with and maintaining your oxygenation. And this can be done by a simple face mask, no any other stories. So always remember, your main goal in your pediatric airway management is to ensure that you can be able to oxygenate your patient and maintain your oxygenation. Next. So what could be the causes of respiratory distress? We know that our airway, we have upper airway, lower airway, lung tissue. This is how Paul has divided it, which makes it very simple for our understanding. So in terms of upper airway obstruction, where is our upper airway? Upper airway is mouth, nose. So anything that is going to interrupt that path is going to cause an issue of upper airway, which can be foreign body, any anaphylaxis, secretion, even edema of the airway, and any crop. So the most first sign that you're going to get in an upper airway obstruction, since it's refusing air to enter because it's blocking entrance, so it's an inspiratory stridor that you're going to get. So this is air entering is being blocked. And the lower airway obstruction is due to asthma, bronchiolitis, or also edema into the lower airways, which are the trachea, the bronchi, and the bronchioles. And beyond that, we are going to the tissue beyond the airway, which is the lung tissue, and can also be due to inflammatory cells issues or even fluid buildup. And there can be pneumonia, pulmonary edema, pneumothorax. And this sign, for the sign of lower airway, since it's already lower, it's usually exhalation that's the problem. So expiratory problem, either an expiratory wheeze or an expiratory stridor. So coming out or air going out is what is blocked. So that's the difference between upper and lower. Upper is air coming in that is blocked, lower is air going out that is blocked. And lung tissue, it can be decreased in or abnormal breath sounds when you do your auscultation. And another thing that can also cause respiratory distress is a brain function or a abnormal respiratory control in the brain, which can be due to injuries like head injury, which leads to increased intracranial pressure or decreased level of consciousness, and also neuromuscular diseases that can lead to abnormal respiratory control. So what do you see in a patient with respiratory failure? Remember, we have a respiratory distress, which will eventually lead to a respiratory failure if it's not intervened early enough. So marked tachypnea, which will eventually go to bradypnea and apnea. A tachycardia to bradycardia, a poor breath sound leading to cyanosis, stupor, and coma. So all this will all depend on how fast we can intervene once we see a patient or a child in a respiratory distress. So to avoid respiratory failure leading to comas. So give oxygen, call for help, put your monitors, and avoid a respiratory failure, or treat your respiratory distress effectively and early. So get ready to do what? To rescue. What are you rescuing? You want to avoid to lead to, next. You want to avoid to lead to, next slide. You want to avoid leading to respiratory failure. You've seen that there's an issue, there's a problem. You're already seeing a tachypnic baby, a tachycardic baby who's already using a lot of efforts to breathe. This is already a child who's in distress. You want to intervene at that particular moment so that you avoid going to a respiratory failure. And what are you getting yourself ready to rescue this child? You need to ensure effective ventilation and oxygenation. And the main important goal, or the most important skill that you need to acquire and you need to have with you, is how to do an effective face mask ventilation. So that's our first goal. That's our first understanding, that we need to have a good technique in doing a good face mask ventilation. The rest of supraglottic ventilation airway, this is a rescue also, which is an LMA, simple to put in. We'll go through them stepwise. And then direct laryngoscope and tracheal intubation is your last resort. This is the last thing you want to think of while you're doing your ventilation or your oxygenation to your baby. Provided you can ventilate effectively with your face mask and you can oxygenate effectively with your face mask, there is no need to force or fixate your mind into direct laryngoscopy and intubating if you're getting any difficulty. So goal is face mask ventilation effectively. And there's all those potential complications that can be avoided. You have to prepare your equipment. You have to know who's in your team, whom do you have in your institution, who can be resourceful for you, and who is the patient that you're working with and the particular challenges that you're dealing. I'm going to repeat, the most important skill is the one that has two beautiful stars: face mask ventilation. So how do you prepare for your face mask ventilation? Select the appropriate size of your face mask that is transparent and soft rimmed and covering your nose to your chin. Understand how the equipment at your setting or at your site is practice function. And also know your supplemental oxygen is there, and make sure all your equipment are working. You have an oxygen flow that is there, and you're able to provide positive pressure ventilation. Remember, face mask ventilation saves lives. So it is important to understand the equipment that is available at your workplace and how to use it. Which type do you have for your face mask ventilation? And when possible, do you need to add oxygen? And which outlet of oxygen do you have? Do you have a wall one? Do you have a cylinders? And availability of everyone that can help you to do. And which clear masks do you have? Always, always, always prepare also your suction and should always be available and very close and functional. So we're going to go deep into equipment for face mask ventilation. Next. Excuse me. So 2 types of face mask ventilation that you can have. Self-inflating bags that we know we all have, we call them ambu bags, right? Artificial manual breathing units. So we all have that in our hospitals. And there's a flow inflating bags. Flow inflating bags are usually used by skill level advanced providers. Anesthetists, they know how to use them. And airway heroes or airway bosses. So in self-inflating bags, we have different sizes. So these self-inflating bags, they are also age appropriate and they give you the volume of that bag that it has. You have to equivalent it with what patient you're having, the size of the bag that you need for that particular patient. And remember, it doesn't need oxygen. It's self-inflating, so it doesn't need oxygen to be able to ventilate the patient. You do not need oxygen to ventilate that patient when you're using a self-inflating bag or an ambu bag. But if you need supplemented oxygen additional, you can put it in if you have it close. So there's a point or a portal that you can put oxygen flow and it will flow in with your 100% oxygen. But you don't need to stop ventilating if you don't have oxygen because it does not need oxygen flow. So you can still ventilate because it keeps on inflating itself. And the oxygen delivered or for the patient to get oxygen, it has to be blown. You can't leave it like that for the patient to just breathe in and out. No, it needs to be pressed or squeezed. That's the word I was looking for. Yes, it needs to be squeezed. And if you need more oxygen, you can connect to the portal where the oxygen can go in. A reminder again, you do not need oxygen for it to help a patient or for you to be able to ventilate a patient. You can ventilate without oxygen because it's self-inflating and it doesn't need so much of a skill. It's more basic, okay? And it can be used by all of us. So a flow inflating bag, this one is the one that is the one that need a skilled provider, and it needs oxygen for it to be inflated. So for you to be able to ventilate, you need to be put on higher oxygen, and it's also age appropriate. And the oxygen that can be delivered, it can be delivered in a very high pressure. And that's the best part of it. And you don't need to squeeze it like the self-inflating bag, because for self-inflating bag, for oxygen to be delivered, lazima you squeeze it. But for this flow inflating bag, you don't need to squeeze. You can leave it like that, and oxygen will be delivered to the patient via the mask. So it's also able to deliver high pressures and therefore are usually exclusively used by anesthesia providers in hospitals. So when we talk about basics, what do we mean by basics? Next. So the basics, airway. Support and open your airway. Always remember, you need to support and open your airway. And there are maneuvers that we can use to open up our airway. We just need to be careful with a certain maneuver that is in terms of trauma or injury or cervical problems, okay, or cervical fractures. So support and open up your airway. Clear your secretion from the nose or from the mouth. Minimize any agitation And there are devices that we can use. What devices can we use to open up our airway? We have oropharyngeal and nasopharyngeal airway. They assist in opening up our airway. In terms of breathing, you need to provide supplemental oxygen and measure your SpO2 to know that you don't give oxygen that will lead to toxicity. Remember, oxygen is also a drug, so it needs to be titrated and it needs to be given when necessary, and in terms of not given an overdose, because it can lead to also oxygen toxicity, which is harmful. So assist ventilation with positive pressure ventilation with your ambu bag or your flow inflating bags, and also administer your drugs if you're having any edema. The emphasis come back again. Your face mask ventilation is a life-saving. It's the one that you need to learn the most. Next. So what do you do in terms of you assessing your patient, our patient's airway, our child or patient's airway? So you need to do an airway evaluation, which is inclusive of all that what you see in terms of assessing your child, the history you're taking. So when you look at your child, you can pick, is your child snoring? Is there any noisy breathing? Is there any cough? Is there any injuries? Is this a syndromic baby? Am I already seeing a difficult mask ventilation? Do I have a small chin? Do I have a small head? Do I have a big neck down, fat tissue of the neck? Do I have a big head? Okay, all those they will lead to you be able to know, am I getting into trouble in terms of ventilating face mask, or am I going to get into trouble in terms of difficult intubation? So every institution should always have or create a writing plan for care of patients with known or suspected difficult airway. You have to write your plan. What are you doing after you suspect that this patient is going to be a difficult airway, either difficult mask ventilation or a difficult intubation? What is my ABCD plan? What am I going to do? What do I need? What am I preparing for? All those. Okay. So in terms of physical examination, next. Airway evaluation in terms of physical, the same thing comes in. You need to observe and see your patient, calculate your respiratory rate in response to your child's age or the child's age. Are they in increased work of breathing? What is the size of the mouth, the tongue, and the mandible? Are we having the teeth? What is our appearance? Do we have any presence of any anomaly? So all these are features that you can just look at your child and pick all this, and all the evaluation before your anesthesia. So now when you generally look at the child, you're picking if this is going to be a difficult face mask, or also you can evaluate by looking and also see if you're picking this is going to be a difficult intubation. So assessing your mouth opening, we all inter-incisor distance, malampathy, thyromental distance, and upper lip bite. This evaluation before anesthesia, they're going to help you to be able to know, am I going to get a difficult intubation, and how am I preparing? What's my algorithm in preparation of that difficult airway, for how am I approaching it? So this is a modified malampathy classification. Remember, we're dealing with pediatric patients, so it's going to be difficult to assess for patients less than 18 months. It's really impossible and difficult for patients below 5 years, because they will not even listen to what you want to tell them. So in terms of our pediatric, it's more of a poor predictive value, but it's used widely because it's easy assessing and easy to pick if you're going to get into trouble, and prepare yourself. So we are all going to the same crisis resource management. You need to plan yourself to plan and communicate the problem, do your action and assessment. All these are in terms of how resourceful and how are you able to manage your crisis and how do you prepare yourself. Okay. So we're going to do an optimization of face mask ventilation. Very, very important that you create a tight seal between the mask and the face. So we all know the EC clamp technique that you put, as you can see from the picture, the thumb and the index finger is forming a C. That's a C. And your middle finger, your ring finger, and your little finger, baby finger, they are forming the E shape, and they are at the mandible. So the C is to make sure you're putting a good seal, and the E is to help you lift the jaw and put your patient in an open airway or a sniffing position to be able to open up the patient or the child's airway. Always remember that your fingers, the ones that are forming the E, they need to be at the mandible, at the bone, not at the soft tissue. Because if you put them at the soft tissue, they are going to cause an airway obstruction, especially with the little ones that we are going to deal with. These babies are very fragile. So the minute you put all those fingers around the tissue, you're going to get a difficult airway that you caused it, or us ourselves caused it. And then you start panicking. Your heart rate goes up. Kumbe, it's just your fingers that needed to move. Okay? So make sure your fingers are at the bone, the mandible, the E fingers, and you open up your airway. So when you're ventilating, make sure you're not giving too much pressure, so you minimize gastric inflation, especially in children. That's the pediatric age. It's if we inflate too much of the gastric, we are going to get another story of difficult airway, problems with inspiratory delivery. So you need to be very careful. So if your child is spontaneously breathing, giving your positive pressure during inspiration at a minimum rate, it's like you're just assisting or synchronizing. Use your lowest inspiratory pressures and give breath over 1 second to allow easy ventilation. So sometimes you're getting a difficulty, so you need to consider two-person technique if you cannot be able to open up the airway and get your patient. And a two-mask or a two-person technique, the same C will be done with the other hand to make sure a seal, and you'll use two hands to do a jaw thrust that will lead to an opening of your airway. All this will not be possible if you don't practice and practice and practice. So you need to practice to make sure you have a good seal between the mask and the patient's face, and your minimum ventilation, and don't cause your blockage by your fingers, and gentle breath are most likely to be effective. Because if you get a stomach full of air, then this will push your diaphragm, remember, making your positive pressure ventilation more difficult. It can also lead to vomiting. Okay? So watch your patient. Whenever you're doing a face mask ventilation, you've already gotten a good seal. So what will make you know that you're doing an effective face mask ventilation? You have to look at your patient. So is your chest rising during inspiration? Are you getting a good condensation in the mask when you leave and let the patient exhale? Remember, exhalation is passive. And at the same time, you can have someone listen to the chest and auscultate. Okay, which other monitors do you have available around you? Do you have a capnograph to use to make sure you're getting a good carbon dioxide curve, so you're ventilating well? Do you have this colorimetric carbon dioxide detector, which is more changing color, like acidity basic? And do you have oxygen saturation? And also, after you've reached your face mask ventilation, you need to know now you need to escalate. You can easily ventilate your patient, that's good, but you need to escalate. Do I put an LMA or do I put an ETT in terms of rescuing? So making sure that you're doing a good gaseous exchange is actually what is required and need in terms of you doing a face mask ventilation, an effective face mask ventilation. So 6 essentials that are needed in terms of you doing face mask ventilation. 1, make sure you're calling for help because you're already in a crisis. You don't need to be by yourself. Reposition your patient, do a good jaw thrust, and use your devices to open up your airway, either your oropharyngeal or your nasopharyngeal. And also you can use a 2-person technique. So the pictures up there are showing us the 2 type. So we have an oropharyngeal, that is the picture above. The arrow is there, and they're all different sizes, and they're all color coded, and they should be measured before inserted. And down here we have the nasopharyngeal airway, and also they need to be measured. So in terms of you measuring oropharyngeal airway, just to know it's something from heart to heart. So use your incisor teeth to your angle of the mandible. That's the size. So you put it there and see if this is the size of your child or not. So our next step that needs to be clarified in terms of escalating is putting up an LMA. A laryngeal mask airway. I call this a Bluetooth mask. Why do I call it a Bluetooth mask? Because you put and you're there, your hands are free, not like the face mask. Your face mask, you need to be there to fix and make sure you have a seal. So when you have a good technique of putting your LMA, you're doing a Bluetooth, or even you can call it a wireless face mask. So your hands are free, you can do something else, and your patient is well ventilated. So this is a supraglottic airway device. It's a rescue device as per American Society of Anesthesiology's difficult airway algorithm. And it's needed the most when you cannot intubate and cannot ventilate scenario. The plans will be gone through, and excellent typical assessment of placement and easy to place it. And it's also good, it gives you an effective ventilation if you have your face mask ventilation not being adequate. There's no need to paralyze your patient when you put in your LMA or your laryngeal mask airway, and you can maintain your spontaneous ventilation if needed. And the proper sizes for this is according to your patient weight. So the LMAs come in different designs, different styles. They keep on evolving. We have different evolvement of these LMAs. We have the iGels. We have different sorry, 1 minute. Okay. So we different evolvement designs. They're the ones that the classical ones that we have mostly. There's iGel that are evolving, the ones that can be used during endoscopy, the ones that can be used suctioning, the ones that can be used in cardiac catheter and labs, in cardiac cath labs. So all these are evolving, but they're easy to place, and they're just in terms of weight correlated. So LMA placement is a direct pressure backwards. That's the way you need to put it, and ensure your patient is deep in anesthesia to allow placement so that you prevent laryngeal spasm. Because remember, you're putting it in the larynx. It's like a face mask on the larynx. Where the larynx is, you're putting a face mask. Just picture the face mask, but now it's at the larynx. Okay. So what are the contraindications in patients with LR for LMAs? We know them. These ones are patients with higher risk of aspiration, patients with refluxes, and inadequate fasting time for patients that are going to theater, and the ones that need a complete controlled ventilation is needed, or it's critically needed. Okay. So how do you place it? So how do you place an LMA? So when you place an LMA from the picture, let's move this is more of a classical type of LMA. The iGel ones are usually direct forwards. I wish we had a picture, but it's okay. More of classical LMA. So the part that is more gray and the hand that is holding it, you're holding it like a pencil. But I know when I say pencil, it's irrelevant because everybody holds their pencil differently. but your index finger is supposed to be underneath your cuff to harden it. And you cuff it a little bit, which is this round thing at the end. So see, this looks like just a mask. So that's what's going to go into your larynx. And after the A is the B, you push it in, do your tilt, and keep and push to your, I know your finger is going deeply in, but if you can avoid your finger going deeply in, that's good. But if your patient is sleeping, then in a deep anesthesia, perfect. Then remove and connect. So you see, when you see at E, the picture at E, you're seeing where your larynx is and where this thing is lying. It's just lying up at your larynx, at the patient's larynx. So that's why it's just a laryngeal mask airway. Okay? So that's it. And I will welcome our next presenter. Thank you very much.
Thank you so much, Dr. Shuweika Salim. That was an excellent talk. I appreciate that. Can everyone hear me? Can you hear me on your side?
Yes, I can hear you. Yes.
Okay. All right. Perfect. All right. This is our breaking point. So I'm going to continue with our discussion, going right into our next slide, which is direct laryngoscopy. So we've covered LMA and ways to determine if someone is in respiratory distress, and if we're going to intubate, if we're going to perform a tracheal intubation, we need to, of course, first establish our indication. So knowing why we're going to be intubating is most important. Gathering our equipment, knowing that we need all of our equipment available and set up in advance is very important. Having suction, obviously, in case there's any type of vomiting, oxygen, your pressure, positive pressure ventilation device, as previously discussed, in terms of to assist with bag mask ventilation. Positioning, we're going to get into on the next few slides, is critical. And then just determining the need for, we have learners on this call in different environments, determining your need for the level of sedation and anesthesia. So looking at optimizing a patient in the sniffing position, there really are three axes that are important. There's the tracheal axis, the pharyngeal axis, and the oral axis. And if we don't properly position our patient, those three axes are completely askew, and you want to make these three line up. Adding something behind the head of an older patient can sometimes align the tracheal and the pharyngeal axis, but not the oral axis. And it's that chin lift that gets us the third axis to line up. So having all three axes sometimes requires some type of manipulation of the airway into the sniffing position. For younger children, oftentimes that have larger occiput, placing a shoulder roll behind in the shoulder area can optimize their sniffing position. And in older kids, as seen in these pictures, placing this pillow behind their head and then elevating the chin helps. Jumping right into direct laryngoscopy, just a quick overview of things to do and things to be careful not to do. So opening the mouth in children, a lot of times in adults, we're taught to use scissor fingers in order to open the mouth. I like to use just neck extension. So placing your hand behind the occiput in order to extend their neck often will open the mouth on its own. Placing your laryngoscopy blade is important to insert from the right side and sweep the tongue to the left. And then in terms of just the mechanics of how we do this, pulling the handle at a 45-degree angle in a caudal direction, and we often teach that you're pulling the handle towards where the ceiling meets the wall on the other side of the room. In that type of force in that direction is the safest way to correctly determine if you can or to grab and obtain your view. Not bending your wrist is important. So that picture on the right is showing that it's very easy to bend your wrist in order to obtain a slightly better view, but that can cause oral trauma, specifically dental trauma. This shows the insertion point of the laryngoscope in terms of where it can go. And in this case, actually a curved blade, such as a Macintosh, typically is placed in the vallecula. And that would elevate the tongue and place the glottic opening in view. To review our airway anatomy, the vallecula is the structure between the base of the tongue and the epiglottis. So it is a potential space where your curved blade would sit. If you're using a straight blade, such as a Miller blade, grabbing that epiglottis in order to get your glottic view of the vocal cords is the key way to do that. Your vocal cords are here. Sometimes you're only going to see the arytenoids, those cartilages just below the vocal cords. So it's important to notice this picture and be familiar with the anatomical variations and what is normal and what potentially you can see with difficult airways versus a straightforward airway. Just to get into some of the grading systems of direct laryngoscopy, that's important to note what grade airway you have, because that's what we chart and that's how we determine if someone has a difficult airway in the future. So when we obtain the best possible laryngoscopic view, and we've optimized our view by placing the tip of our blade in the proper place, if we see all of the vocal cords, that is considered a grade 1. If we see just part of the vocal cords, not the entire vocal cord, then it's a grade 2. And then if we see just the epiglottis, grade 3. And if we're really optimizing to the best of our ability and all we see is tongue, then at that point it's a grade 4, the most difficult type. Once we place our endotracheal tube, this picture nicely depicts how and where the endotracheal tube is placed, but potentially why it is so difficult. So, as you're placing the endotracheal tube, you're notice that the trachea is anterior to the esophagus, which makes our techniques critical and potentially more difficult. And placing that endotracheal tube just below the vocal cords so that the cuff is lying below the cords can be inflated and prevent any kind of leakage, and we're able to ventilate at that point. Just a few things to note in terms of ET tube selection. These are critical things to memorize when trying to determine the proper endotracheal tube size. So age divided by 4 plus 3.5 will get you the proper ET tube size. A lot of times I'd like to have that size tube plus a half size tube smaller available in case these are estimates. In case the airway, that tube is too large, you can use the smaller size as well. Using a stylet can be controversial in terms of if efficacy is versus potential for injury. I say styleting tubes in infants is always advantageous in order to have the first pass being your best effort and potential success rate being higher. The depth of your tube, height in centimeters divided by 10 plus 5 is an incredibly accurate way to determine the depth of your tube. Sometimes we use the endotracheal tube size times 3. However, that also is based on the fact that you've chosen the right size tube, whereas this is independent of the size tube that you use if you use the height in centimeters divided by 10 plus 5. So considerably more accurate. Once we place the endotracheal tube, we want to inflate the cuff. We don't want to inflate the cuff too much to cause any type of trauma to the airway, but we do want to prevent any kind of leakage and be able to effectively ventilate. So inflating the cuff to a pressure of 20 to 25 centimeters of water is ideal. And then, of course, confirming breath sounds, looking if there's chest rise, and finally, presence of end-tidal CO2. Just to briefly talk about indirect laryngoscopy. There are many different ways or very many different instruments to perform indirect laryngoscopy. One of the most common ones that we have available is the glide scope. And this is a 4-step process that is different than direct laryngoscopy. And most importantly, it's different by the fact that it is a midline approach. And the step one is looking into the mouth and placing the tip of the blade in the midline as opposed to sweeping the tongue, going right down the midline. And as you insert the blade, at that point, and only after that point, then looking at the monitor. And the monitor helps considerably to obtain your view and visualize exactly where you're going to place the tube. It's important to note that indirect laryngoscopy has a major advantage over direct laryngoscopy in terms of the camera being at the tip of the blade. And that advantage makes it considerably easier to obtain a proper view. So if we have this instrument and this tool available, that can help with difficult airways, especially with infants. Step 3, look back at the patient, looking in the mouth, insert the endotracheal tube, making sure that it is hugging or being very close to the blade itself, so that you don't really need to have an independent angle on the tube itself, but follow the path of the blade, which is what makes it considerably easier. At this point, do not look at the monitor until you've passed the tip of the tube into the mouth. And step 4, complete your intubation by looking at the monitor and advancing your tube through the vocal cords. Of note, removing the stylet, specifically in a glasgow, can be quite difficult. So you have to hold on to the tube and to ensure that extubation does not occur. Okay, a few more tips as we get near the end of our talk that I wanted to cover in terms of pediatric airway management particulars. Airway management is considerably more difficult in children less than 1 year. In fact, any types of related problems that occur are 4 times more common in kids less than 1 year. So having a particular challenge is kids less than 1 year, even more so kids less than 1 month. So neonatal airways are more difficult than most pediatric airways. Why is it that we have potential for desaturation much higher in infants compared to older children? That's because infants have an increased oxygen consumption per kilogram and a higher minute ventilation to FRC ratio. So for that reason, we need to really emphasize pre-oxygenation. We really need to emphasize that our first attempt should be our best attempt, and that the potential for early and quick desaturation is quite possible. And that's simply based on their physiology. Infants and children with upper respiratory infections also have a higher risk incidence of postoperative laryngospasm and bronchospasm. When we're in the operating room and we're considering elective cases, we often try to postpone these cases for 3 to 4 weeks, just because of the higher risk of bronchospasm and laryngospasm. Other key points to note in terms of difficult airways: dysmorphic facial features, a history of obstructive sleep apnea. Both can lead to more difficult face mask ventilation. The potential for face mask ventilation can be as high as 6%. However, unexpected difficult intubation is rather rare. As mentioned previously, difficult intubation is more common in our younger pediatric patients. And luckily, the can't ventilate, can't intubate scenario is actually quite uncommon. So what are the major factors that lead to complications of airway management? There was a large study out of the United Kingdom called the National Audit Project 4. And this looked at the incidence of major airway complications and what led to airway complications and what themes they learned from this large study. Death, brain damage, emergency surgical airways, and ICU admissions are what they were considering. And looking at that specifically, they had several general factors that were identified. These general factors were level of education and training, failure to anticipate. Sorry, this is auto advancing. I'm just going to stop that for 1 second. Failure to anticipate and plan for failure. In addition, poor airway assessment is so important to have a proper airway assessment in order to prevent this type of event. Failure to follow recommended practice in terms of the difficult airway algorithm, and failure to change strategy when in trouble. I'm trying to persist with the same type of airway intervention. Human factors that led to adverse conditions in this involved poor teamwork, poor leadership, poor judgment, poor communication. All of this emphasizes the need for practice. The single most common cause of death from this was aspiration. Based on this, there is a 3-column model of airway evaluation that I wanted to touch on just briefly, since we're running short on time. We have just a few minutes left. And in this model, looking at the airway as in terms of the anterior, middle, and posterior column. The anterior column is the submandibular space, the volume and compliance of that space. The middle column looks at just the interference of ventilation at the laryngotracheal level in terms of infectious processes and physical processes. Infectious processes, specifically the epiglottitis, neck abscess, and physical processes such as neoplasm, subglottic stenosis, foreign bodies, and bilateral vocal cord palsy. And then finally, just assessing the posterior column, and that is mostly looking at the spine, knowing that the potential for limited C-spine mobility in conditions such as achondroplasia, Down syndrome, specifically looking at patients with C-spine fusions, knowing that there's difficulty with manipulating their spine, and any type of patients that have potential for C1, C2, atlantoaxial instability. Those similar types of patients could require immobilization. All right, the last few slides. How do we prepare for failure? Looking at the 2022 ASA difficult algorithm. It's important to note that when considering a difficult airway, that we call for help early. I know this is a theme that we discussed earlier, but it's really important that we discuss that further. Assessing the likelihood of a difficult airway in advance and coming up with a plan in advance is critical. In this type of algorithm, in adults, we consider awake intubation whenever we have a very difficult airway. However, in children, that's typically not possible. We will typically still sedate, provide anesthesia, and then determine the best method forward. And the best method forward in those situations is maintaining spontaneous ventilation. Actively pursue, if I can really get one point across on this slide, it's actively pursue opportunities to deliver supplemental oxygen, to provide apneic oxygenation. What does this look like? It really is in the form of nasal cannula, high flow nasal cannula. If you have the opportunity to potentially place a nasal trumpet in the nose in order to better facilitate the delivery of nasal cannula, supplemental oxygen, that is a great way to prevent deoxygenation, to prevent apnea when trying to manipulate the airway from more advanced techniques. And then limiting the attempts in terms of the number of attempts of one provider or of one type of technique that you're trying if unsuccessful. Most importantly, supraglottic airways, as Dr. Salim mentioned, critical to managing the can't ventilate, can't intubate scenario. These are based on weight, and if unsuccessful, of course, knowing how to provide surgical and needle cricothyrotomies and tracheostomies. And the last slide here really gets into, in terms of looking at the difficult airway and to takeaways from the pediatric side, emphasis on performing a timeout before starting a difficult airway, having a team-based approach, always maintaining the depth of anesthesia is important, in order to prevent those critical things we talked about earlier, which is in the form of laryngospasm, bronchospasm, and being careful if using airway exchange catheters because of the potential for trauma. These last two slides look at recent literature. This one, when the 2022 ASA practice guidelines for the management of difficult airway were updated, this was one article that was published by the team that directed these new guidelines. And the take-home point from this article was you could post these 6 things in the airway, in the operating theater, in the OR, as things to consider when difficulty airways are being managed. Always ask for help before you start. Always use supplemental oxygen. I'll mention that again because it's so important. Use advanced airway techniques as your first attempt. If you have the ability to have a video laryngoscope, potentially use that as your first attempt as opposed to going to DL, direct laryngoscopy. Do not persist with failing techniques or failing providers, and then do not delay emergency front of neck access or ECMO if available, if you cannot oxygenate. And the last piece of literature that we'll talk about is just this article from a recent article from 2021 about difficult tracheal intubation in neonates and children that also emphasized the use of routine video laryngoscopy and apneic oxygenation, and then always having an experienced anesthesia provider, either in charge or as a backup if available. So in summary, our learning objectives were to recognize and evaluate impending respiratory failure, to describe proper airway evaluation, to list effective face mask ventilation techniques, to explain LMA placement, to describe intubation, which we covered direct laryngoscopy and video laryngoscopy, to list factors that led to major complications in airway management. And then we briefly touched on the ASA, American Society of Anesthesia, difficult airway algorithm, and a little bit of literature related to that algorithm. So with that, I will stop. Looks like we're just a few minutes over our time, but Dr. Salim and I would be happy to answer any questions for those that have them. Please feel free to enter your questions into the chat and or unmute yourselves and ask questions directly. Thank you so much.
Thank you so much. I appreciate. We always told by my lecturers, if there's no question, there's only 2 meaning. Either they understood nothing or they understood everything. So I'm
Very
hoping
true. I
they
hope it's the
understood.
latter. We covered quite a bit of information in this topic, and I think it was I hope it was a little bit of some relevance to everyone, because I know we had a wide variety of airway learners on this call.
Yeah.
So we covered everything from the very basics to something a lot more advanced, and it's such a huge topic, pediatric airway management, that this could go on for hours and hours. So we tried to squeeze in as much relevance as we could. We really appreciate your staying and participating and
Yes.
and I really enjoyed working with you, Dr. Salim.
Me too. Thank you so much. It's appreciated.
Thank you both so much, Dr. Salim and Dr. Liston. It was an excellent presentation and we all really enjoyed it. And it's a wonderful start to such an educational collaboration between University of Washington, Naivasha Hospital, and University of Nairobi. Thank you so much.
Thank you very much for your presentation. I'm Angeline. I'm a pediatrician. I really enjoyed the presentation. I would really look forward for more detailed or more advanced pediatric lectures, specifically in ICU care. Generally how to set up the vent settings, resp care, and different conditions and and remind us on how to adjust our vents accordingly. So I hope the other lectures may touch briefly on that. Thank you.
Thank you for that feedback. We appreciate that. I think the lecture series is still being tailored. I know there's 2 other topics that are upcoming, but I think your feedback in terms of what is important for your area of care and how we can potentially incorporate that into future lectures is very valuable. I appreciate it. We do have one question that's popped up in our chat, and it says, how do you decide the blade size for a laryngoscope?
I can briefly say something about it, then you can see if you need to add onto anything more.
Yeah, sounds great.
Okay, so in terms of you using which blade or size you're going to use is not ideally specifically telling you which blade size you can use, but they're just regularly different sizes. So and different types. So we have the ones that are straight, and we usually use the straight one for pediatric patients. And they are at level of 0, which is the smallest that you can use for neonates and prematures. And then you have a 0, and then you have a 1, and you have a 2. But you have also mark, the ones that are carved, and they go with sizes as 1 to be to the smallest. There's a 1 and there's a 2, and there's a 3. And 1 and 2 and 3 are the ones that we can use for young children or for pediatric in terms of mark. But I don't know if there's a specific formula on how to know which blade is for which size of child. Anything to add on to that? If there is, maybe you can also enlighten me.
No, I think that's correct. And I just noticed that Dr. Gacki put in the chat, a rough guide is the size of the oropharyngeal airway that you would use. And that is very true. It does become more, I feel like in my head, I have an idea of what sizes to use. For example, using a Miller 1 in infants, and as you don't really switch to a Miller 2 until you're considerably older. And max sizes, as you mentioned, really depend on the size of the oral airway or the patient's tongue. But determining that also just comes along with experience, and as you intubate more, it becomes more intuitive. But it is a rough guide of the size of the oral airway is a great way to size up potential, like the use of a MAC blade. There's also been posted on here details of our next session. In that topic will be PALS and resuscitation, and that is Dr. Andrew Pentia and Dr. Durba Faisa on February 13th at I believe it's at the same time. We do have another question in the chat. It says, great presentation. Is the recording available? All these, the recording of every lecture will be uploaded, and I'm not sure of the turnaround time on that, but I believe, within the next, typically within the next couple of weeks, we should have that available for viewage. Thank you again for everyone for attending. I think we will stop there. If any other questions come up, we can also just provide our contact information. I'm happy to answer any further questions if you have them, and help in any way that I can.